What I'm going to talk about today is to look at language. And in nursing, we would often start this sort of a topic with a discussion about standardized nursing language. And I know that standardized nursing language is a big topic here in Estonia. And it's a big challenge for undergraduate educators and for new students, because sometimes what they see in practice is different from what it is that's best practice taught in a college. So I'm going to try and explore this complex topic, but as an overview, rather than the detail of it, because it's a really big topic. And to briefly explore the different aspects of So, first of all, thank you to Professor Christie and to the Dean and the staff and the students here at the college, and of course to Tallinn and Estonia generally, and I've said already how much I love coming here. And as always, my apologies for presenting in English. So I could present it in French if you wish, but maybe, maybe that doesn't really help. Maybe one day, a bit like the British ambassador, I might be able to learn some Estonian, but not before today's lecture. So that's the objective. And we've covered these slides already. So let's just think about language, generally language. And we'll move to nursing in just a minute. But language is everything, and the words that we choose to use are everything. Personally, professionally, in every respect, language is everything. But it's heavily influenced by a lot of things. So if you think about it, it's heavily influenced by family, when we're children especially, and our extended family. It's heavily influenced by education, and the education that we're privileged to receive, or in some cases we're unable to receive, depending on our social circumstances. And of course, it's heavily influenced by social structure and the structure around us. And by that I mean that actually it could be very positively influenced by that, and we could be gifted with being brought up to speak in a certain way that will help us in our life, or maybe not. Maybe in a way that's not going to help us in our life. So there is an element of accident of birth around the way in which we use language. And then, of course, it's about culture. And culture is multi-axial. By that I mean that actually there are so many people now who have been born in one country, educated in another country, working in another country, married or in a partnership with somebody from another country. It's multi-axial. And all of those things are key to language. And then, of course, local dialect. And in many countries, there are multiple local dialects. In Britain, there are hundreds of local dialects. And particular phrases that are only used in sometimes one town or one city. So complex. And then, of course, our attitude to language. Of course, there's the issue of our mother tongue. And some people have more than one mother tongue, of course. And then learned languages after that. And then, of course, we make some professional choices in our life. We make professional choices with our career, our choice of education, if any, in some cases. and then our exposure within that. So if we take the example of, let's pull it into nursing for a moment, but if we take the example of people who choose to work in mental health nursing, their vocabulary is very different from people who choose to work in the ICU. So then travel. Travel radically changes our attitude to language and our exposure to different worlds. And people who've travelled a lot and who've had to communicate across different cultures typically get very good at working out what not to say rather than what to say. So our exposure to those different worlds is an educational process, so long as we're open to it, right? So long as we have insight and we can reflect. We can, of course, be closed and not learn anything from those experiences. But most people, I would hope, would learn from that experience. And then religion and other belief systems may influence our language too. In some cases, very heavily. If we look at the Middle East, religion very heavily influences language and use of language. So that's just my little list, but you may be able to think of other things that influence language. Those are just the things that I thought of, but maybe at the end when we open up, you'll have thought of different things that you want to include, and we can talk about that. So then, nursing and the language of nursing. So communication in nursing, like communication generally, is everything. And the language we use, whether it's verbal or written or in IT systems or body language, is key. But it's really complex. And very often we just speak thinking this is easy, but really it isn't easy. It's highly complex. And one tiny change of body language changes everything. And if you know what it's like if you meet somebody and they're doing this and they have a face which is not a happy face. But they say exactly the same thing as somebody who's saying, "Hi, how are you?" That message is received in a completely different way. So we can't exclude body language when we talk about language, because it's all part of the same thing and the way in which we communicate. The next one for me is that it's very easy to get it wrong, particularly across cultures. Something that's acceptable to say in one culture may not be in another culture. And that changes constantly, even in regular life. So if we think about, in many cultures, America, Britain, we think about the huge move to be politically correct, in other words, to say things that are neutral. So I'll give you a really strange example, but it's about language. So normally, up until recently, when you got on board a British Airways plane, they would say, "Good morning, ladies and gentlemen." Now they're not allowed to say that, because not everybody identifies as either a lady or a gentleman. They now have to say, "Good morning, everyone." Now, we might find that funny, or we might find that ridiculous, you know, and my mother would be in the ridiculous department with that. But it's very generational. But it's a really good example of how language changes over time, and the acceptability of certain phrases change over time. Clinically, it's very easy to get it wrong, particularly when we make assumptions about people. If we assume that people's social circumstances or setup are the same as our own, when they're not, it can be very difficult. So different cultures communicate very differently. And there's a reference here to Erin Meyer's work, 2016, which is a book about culture and language differences. And I have the book, of course. People know that I travel with lots of books. And but what she's tried to do is to look at the way that typically within different cultures we communicate. And there are some radically different examples within that. So we know that in some cultures people are very blunt or honest. In others, they're not. And I'll come to some examples of that. British people typically are not very honest when they're speaking. They use a lot of words, and a non-British person will think, what is he talking about? Like, can you just tell me what you want? Because they've already used 400 words. Whereas a Dutch person would use 3 words, but you'd know exactly what they wanted because they're blunt, you know? Or a German person, maybe. So it's very different in different cultures. And then, of course, different professions in healthcare communicate differently. I touched on the differences between, for example, somebody working with a vocabulary in mental health versus somebody working in the ICU. But there are multiple other differences. And certainly if I think back to the way in which, particularly in the 1980s, some physicians communicated, even the things they wrote about patients, it was a very particular style of writing and communicating that nowadays would not really be acceptable. But I think also some professions communicate in a much more functional way, and other people in a much softer way. So if I think about the difference between the way that a physiotherapist might communicate versus a psychologist, usually one much more functional and one kind of less or transactional, and one less so. And of course, that communication style is sometimes linked to our attitudes to patients and family members. And we're going to talk about that in more detail. Because we are, all of us, only human. So we all have biases, views, and that we've built over our childhood and young adulthood and all the rest of it. And if we sometimes meet a patient or a family with a very different values set to ours, it's quite difficult. You know? You might think that actually the food choices that you make for your family or children or whatever, you might think of one particular way of doing that, and that's very important to you. But then you meet a family where really they don't care about food choices, but you have to communicate with that family. So in your head, you've already got a disagreement. And it's difficult not to let that disagreement come out through your mouth because it's already in your head. And then everyday language that nurses use, of course, is simply a reflection of society, because nurses and midwives are just part of society. We're not excluded from society. So actually, language that we use with our families, with our friends, in social media, in text, speak, all of that is language that can creep into the workplace, of course, and creep into our practice. So I'm painting deliberately a complex picture because this is a complex topic. And we're not going to solve the conundrum of it this afternoon, but we can continue to talk about it a little more. Oh, why isn't this working? It's died. No. The battery's okay because...
Yeah.
No. It's died. Oh. Those ones.
Oh, no, it's working.
No, it works. Okay. It's because you came here, that's why. So, now for something completely different. But of course, language links heavily to culture. And I don't know if anybody here has been to New Zealand. It's a long way away, really, a crazy distance. But New Zealand is really interesting in lots of ways. Not just because they film some amazing movies there and they have great wine and other things like that, but it's also really interesting from a healthcare point of view too. And this hospital you see at the front, the old bit you see at the front there, was, let me see if I can make this work, this bit here, is in a place called Palmerston North. And the matron of that hospital, you can see her here, was the first registered nurse in the world, because New Zealand was the first country in the world to register nurses. And so that's interesting, but not really anything to do with culture or language. The interesting thing about New Zealand is that in New Zealand, they have done a lot of work on what they call cultural competence. And for them, understanding culture and language is as important as a competence around giving IV drugs or resuscitation or something clinical. And everybody in a hospital has to do cultural competence training. So has to understand, for example, the indigenous people of New Zealand, the Maori people, and their culture, and some of their language. And probably New Zealand have led the way, not just in healthcare, but it's a lot in healthcare, around this this concept of cultural competence. And you'd find a lot written in literature, in the research, about cultural competence from New Zealand. And whilst you might think this is not really relevant to Estonia, it is. It's relevant to everywhere, because actually the way in which we develop people and their understanding of culture, and therefore their understanding of language, and the link between them, is relevant to every country in the world. And their framework for developing cultural competence is really impressive. And it's actually not just regarded as best practice, it's a legal requirement that people have cultural competence training. So this link between culture and language is like this. Not just in New Zealand, but of course everywhere. It's just that in New Zealand, they've gone a little further in actually a better understanding it and pulling it together as a framework. And the current head of nursing in this hospital, by the way, she doesn't look as scary as this one here. She's quite normal. So the cultural differences in communication and language, I suppose the key thing about it all is that just like with buying clothes, one size does not fit all. So we can't have one way of communicating and understanding culture and think my way is the only way and everybody has to understand my way. It doesn't work like that. We have to understand that one size does not fit all. And a failure to understand that can lead to some really significant misunderstandings, particularly if we link that to the assumptions that we make about people that we have no evidence for. So within this book is this thing called the Anglo-Dutch Translation Guide. which is one example of the way in which we can get things wrong. And this little guide is really making fun of British people, which I'm good with. I'm British, but I live in France, as you know. So I'm good with making fun of British people. But, and I'll just give you an example. So what this author has done is to divide up what British people might say, what they might mean, and what the Dutch would understand. But you can relate this to any language or culture. So British people might say, I was a bit disappointed. What a British person means by that, I'm very upset and very angry. Okay? What the Dutch understand, it doesn't really matter. Because British people don't always communicate effectively. That's just one example. But often, for British people, it's because they understate everything. So if you speak to a British person, particularly older person, how is your pain today? Oh, it's okay. That will mean it's bad. Now, if you don't understand that, of course, how can you deal with the pain? You know? Because they're not telling you really what it is, which is why we would say to them, well, out of 10, give me a score out of 10 for your pain, because maybe you might get something more out of them with that than how is it okay. So understatement often. And there is this story of this airline captain who was flying over Indonesia, and he's supposed to be the master of understatement, and all 4 engines on the plane had failed. And he made the announcement saying, we have a minor technical problem. Which is a very British way of dealing with things, always to understate. But then, if you think of something completely different, in Japan, their communication style is very different. And for them, much of it is communication based on age, and attitude to age. And so even in Nanda, actually, when I had been president of Nanda, the next president of Nanda was a Japanese lady, Dr. Shigemi Kamatsuru, and she wouldn't become president to start with because an older nurse wanted to be president. So in my culture, that wouldn't happen. It would be who was regarded as the best one, regardless of age. Whereas in Japanese culture, age is really a big deal, you know? So the respect for elders is really a big deal. And then when we're using language in nursing or anywhere else, there is this whole thing about how we express the backstory. So why am I asking you to do this thing? Because different cultures like things explained in different ways. So we know that some of European countries, the kind of old European countries like Italy, Spain, France, they very much like to know the theory of why you want something done, not just to do it. And that's because, of course, those countries are really where kind of the concept of philosophy was born. And so many of those people have been grounded in philosophy and theory, and they like to know why. Whereas in somewhere like America or Australia, they're not bothered about that. They're happy to jump to a solution rather than knowing the why and the theory. So of course then, on the final thing here, which is really significant with communication, is whether or not when a nurse, for example, moves from one country to another, either as a nurse or just as a person, whether or not that changes their DNA. Does that make them less of the country they're from? Probably not. So actually very inbuilt attitudes, views, understandings of things that people have developed over many years in one culture or country that will impact their language as well, they bring with them. They're not just going to change because of moving to a different country. And as, of course, around the world, we see huge migration of healthcare professionals, that's really a challenge in many countries. And how you assimilate that is really a challenge. So, attitude influences our choice of language. Now, I don't know whether many of you have heard of the concept of the unpopular patient. But the unpopular patient, there's other terms you can apply to it. The unpopular patient concept was first identified in the literature in 1973 by this author Stockwell. And I have managed to find actually the original piece of research. It's not very easy to find 1973 research, but anyway, it's there. And when you read it, it's the sad thing about reading it is that since 1973, which is a long time ago, we haven't really improved everything in nursing. We still have the concept of the unpopular patient. Several other authors since then have written about it, and there's some other references here. Johnson and Webb have focused much more on when a nurse meets a patient, the social judgments they make about that patient, before really even sometimes understanding the person. And then Kelly and May in 1982, also a long time ago, wrote about the good and bad patients and the patients who are cooperative or uncooperative. But very often, of course, it's because we are not really understanding their motivation and what's important to them. And this concept of unpopular, I remember very, very well, very clearly from my own days as a student of nurses talking about patients, and this one is, bad or unpopular because they're not doing this, or they won't do that, or they won't cooperate, or they're rude, or something like this. Anyway, there are some references there. There are many more, by the way, references in this area. It's just 3. But this attitude towards a patient, of course, changes our language significantly. Maybe not our standardized nursing language, but our human language. So our language is often driven by the unpopular or uncooperative one. And of course, we do need, when we get into this, we need to really make a fairly rapid decision and differentiate between those people in our care who have capacity to make choices and those who are a risk to themselves and others, or could be a risk to themselves and others. And this, of course, may include a whole range of things, from mental health to public health issues. So non-compliance with a drug for tuberculosis, for example, is a public health issue, right? And if you think about the whole, during the pandemic, the public health issues around that, but with mental health issues, often it's a much more individual thing. But it's difficult because how do we approach the unstable diabetic who refuses to change their diet? How do we approach the vascular patient who refuses to stop smoking? Or the individual who continues to want to practice risk-taking behaviours, which we may not understand. We may not understand why this individual wants to continue to take drugs or have unprotected sex or whatever it is. We may not understand why, but for them, they will probably understand why. And then, of course, there would be something like the immunosuppressed cancer patient who wants to go to his daughter's wedding. But we know that by doing that, he's probably placing himself at risk, being around other people. But all of this, of course, is about motivation, isn't it? and self-actualization. And of course, for that person going to his daughter's wedding, that would be his priority. It wouldn't be, I might put myself at risk of catching an infection. I can deal with that if I have to deal with that, even if it kills me. But I want to be at my daughter's wedding because that's the thing most important to me right now. And as nurses, of course, we have to come into these interactions with an open mind, trying to think, actually, what's most important for this person as a holistic being, not what is most important for me as their nurse, and trying to control them. It's a different thing, right? There are some really extreme examples in the literature, which even I find difficult to read and difficult to understand. And you'd find a lot now written in this area, especially from the Middle East and from nurses working in the Middle East, about self-actualization amongst terrorists. And there have been a few amazing studies about how delighted, I don't know what other word to use, how delighted some young men were to lose a limb from a bomb, because in their eyes it brought them closer to God. It's about their self-actualization. Now for us that might be something so removed from our reality as to almost sound ridiculous. But actually for those young men, their relationship with their God is the priority, not having a leg. And you'd be surprised how many of those studies there now are. And I'm kind of impressed, actually, with those nurses who are doing those studies, because their minds are open, they're not closed. And I read them and think, oh my goodness me, this is, in my estimation, I'm struggling to understand this, you know? But actually, I think it's great that nurses are researching these topics, because without them researching that stuff, we don't understand the whole human condition. Less radical, of course, are many, many, many papers that you'd find from women who've had breast cancer, who actually have self-actualized as a result of that journey. Not all, but some. And have felt closer with other women as a result of that journey. So all of this for me tells us that we can't come at this with just our thoughts. We have to come at this, all of this, with an open mind. So, standardized nursing language was probably what you expected me to be talking about at the beginning, but I just thought I would take a different path today, and we have plenty of time to talk about standardized nursing language. A detailed discussion about it, though, is beyond the scope of this talk. But of course, the aim of standardized nursing language, and has been the aim of standardized nursing language since the early 1980s, is to provide a consistent, evidence-based tool to improve communication between nurses and other members of the patient care team. And we know it improves communication, and we know it improves patient safety. And it enables, of course, nursing to be taught and researched and organised. And without standardised nursing language, we can't really do that. It would be very difficult to do that. And of course, at its most basic, if I say pain, do I mean acute pain or chronic pain? If Professor Christie and I are communicating about something and we're not using standardized language, we could be speaking about two completely different things. In English, we would say comparing apples and pears. I don't know what the Estonian equivalent of that is, but comparing two completely different things, even though we're talking about pain. But if you think about the definitions, those of you who are familiar with NANDA, the definitions of acute versus chronic, they're quite different. They're not the same at all. So unless we understand those definitions, then actually we fail in our communication before we've even started communicating. Likewise, if I say anxiety, do you understand that concept, or do you understand the concept of fear? So those are the most two basic ones from the entire classification, actually, and always the two that I use to try and explain this. Some of the others are more complex, aren't they, to unpick and to understand. But the key, and this is why, of course, NANDA works, and tools like ICNP don't work, and you would expect me to say that as the former president of NANDA, but anyway, it's true, even though I'm saying it's true. But the key is the definitions and the defining characteristics. Without definitions and defining characteristics, you might as well not have a standardized language. Because unless we both understand the difference between acute and chronic pain, then we might as well not bother. Just say pain, which would be ridiculous and a waste of time, but actually without the definitions and the defining characteristics, there's no point. And then, of course, increasingly important is the underpinning research. And for many years, in the NANDA classification, you would find nursing terminology put into that classification without, if I'm honest with you, much research behind it. Now it's different. Now there's plenty of research behind pretty much every one of those terms, and quite a strict protocol around saying unless there is research around them, they get taken out. So that's, and of course they're reliant on people doing that research. So NANDA have led the way internationally with this work, and for those of you who are master students, we will probably get into some more discussion about standardized language over the next couple of days. But in Estonia, of course, Tallinn Healthcare College have led the way with standardized nursing language, and with NANDA in particular. NIC and NOC also, nursing intervention classification and nursing outcome classification, two slightly different standardized languages, but also super important. So we'll have time in a minute for questions, but as I begin to draw this to a close, our role as nurses then, just to kind of summarize some of this stuff, is to try to put our biases to one side. It's difficult because we're, like I said earlier, we're just human. We're not superhuman. And we come to practice as a nurse with all of that stuff in our head, from our childhood, our socialization, our family, everything. But we have to try to put our biases to one side. And I suppose never assume that we know, because we don't know until we ask, you know, and or until we find out about the person. We don't know. So we can never assume. In Britain, for many, many years, we used to say, treat patients in the way that you would like to be treated yourself. It was a nice thing to say, but now we wouldn't say that. We would say, I don't know how. I'm not you. I don't know how you want to be treated. So I'll ask you, how do you want to be treated? Because I'm not you. I can't make assumptions about you. I don't have the right to do that, because you're your own person. Understand that the way in which we wish to be treated may not be the way others wish to be treated. Seek to understand, and later seek to be understood. That's really key for me. And it's a big thing for me in relation to clinical leadership, actually. That so often leaders, not just nurses, all clinical leaders, want to make their point before understanding what's going on around them. And it's like driving down a road, kind of not thinking about the traffic that might be coming from the side. You know, it's not very safe. And then I suppose really appreciate different life priorities and motivations. So, you know, your priority might be to keep that cancer patient with immunosuppression safe and free from infection. his priority might be to go to his daughter's wedding. And somewhere in the middle, there's probably a compromise that you can make around that. In clinical documentation and communication, to seek to communicate effectively, consistently, using standardized nursing language. It is pretty much the only way. And I think in one-to-one communication with patients and families, to seek to communicate effectively by adopting a style of communication that is understandable and effective to that person. So what is understandable and effective to you may not be understandable and effective to them. Which kind of sounds a bit patronizing, like we know best, but it doesn't mean, I don't mean it in that way. What I mean is that we have to understand a bit about that person before we can know how to communicate with them. So, we do have time for some questions, but if you'd like to see some more of Anne's work, then, and you're on Instagram, I'm sure many of you are on Instagram, then she has a lovely Instagram account, anne.stevens.artist. If you would like to know more about clinical leadership and all the work I do in clinical leadership, you'll find it at leoleaders.com. And there's an Instagram account for that as well, leo_leaders_UK. And of course, that is my email address if anybody ever wants to get in touch. But I'll pause there and see whether anybody would like to ask a question or make a comment.
Thank you